Thank you. So today's topic is a discussion of private health insurance in the U.S. We're going to review some data on who has insurance and who doesn't, private insurance, that is. And then after that, we'll talk about what considerations a hospital's, I'm sorry, the CEO of an insurance company faces in trying to have their operation be viable financially. And the pictures include two of the five largest health insurance companies. United is the largest. And here we're taught, and much of it is private health insurance that you get as a consequence of your work. And Dr. Dolkar earlier this week laid out the historical foundation of this model here in the US where people get coverage through their jobs. So I'm not going to review that history. We're going to do more of a snapshot of the most recent years for which data are available, which is around 2020 or 19, 20, sometimes 2021, a snapshot of who's got private insurance, who doesn't. And one of the issues with covering, okay, so a lot of times data is compiled a couple years later. That's very common. The census gives out data on health insurance every year, usually in September, and that'll cover the prior year. So in September this year, a couple months from now, they'll give out data on who is covered in 2023. And that'll be the first time that's available through that very reliable source, which is the U.S. Census. So you know the history of how this all came about, but let's just go through the data. There's 340 or so million people in the United States. 282 million are somehow employed, maybe part-time. They could be 13-year-olds who have a paper route or whatever, but 265 million work for firms that offer at least some health insurance to at least some of their employees. And notice the big discrepancy between small firms like a local gas station who might have 3 or 4 employees covering different shifts, convenience store, something like that. On the other hand, 99% of large firms like UPS or Walmart, who has outlets throughout the country. So we said at least some coverage for at least some employees would be 265 million, but 217 million are actually offered coverage by their employer. But that's not the number of people that are covered through their employer. That number is 155 million. So about 56, that's 56% of Americans overall who are not children. And 127 million people work but are not getting coverage through their employer. Now, let me just say, this is not 100% a sort of failure of the employment linked model, because some of those people are married or they're young and they're getting coverage through their parents, or it's a spouse and they're getting coverage through their spouse. They're married and they're getting coverage through their spouse. So if you're getting coverage one way, there's no reason to have duplicating coverage from 2 different sources, especially if you're paying for both with a meaningful amount of out-of-pocket cost. So the 127 million who are working but don't have coverage through their work, that's not a disaster, but in many, many cases, I don't have the data on what percentage. I would suspect it's 75 or 80%. It's not that they're getting coverage through someone else. they're not getting coverage through their workplace, and they may not have good coverage at all. And has I don't know what Dr. Dolkart's gotten to yet, but has he gotten into any details on Obamacare, the ACA? He has. Okay. So some of those 127 million have coverage through Obamacare rather than through their employer. And in some of those cases, their employer actually gives them some money to help them into Obamacare. So that's happening a lot too. And sometimes, since Obamacare plans and a lot of other plans, most plans have big out-of-pocket spending for deductibles and things like that. Some lucky people also have employers who kind of give them some money to help with the deductibles too. So that happens sometimes. These are in cases where the employer is not really providing insurance directly through the employer, but sort of just helping them get onto Obamacare, the private part of Obamacare. So anyway, that's what happens. But I'm not for employers who give their employees a little bit of money to get them Obamacare. That's highly variable and it's not well reported. So I don't have specific data on that. So but they're included in the 127 million. Let me get beyond the slide. I hope I can. There we go. Okay. So note here on these graphs that between the years 2011 on the left and 2021 on the right, there's been a very substantial increase in the cost of getting health coverage, and going from 15,000 to 22.2. And what I was going to say earlier is that when we're starting to include the COVID years, very specific things happen in 2020, different things happen in 2021, different things happen in 2022. So the data become a little more problematic. And I have to tell you that just in the last year, I think there's been a level of inflation we haven't seen in the United States, maybe ever, and are not likely to see soon. And I have to say that some of this is not due to the failures of multi-payer healthcare like we have in the United States. It's workers who are burned out at work demanding higher pay, and they're demanding it with their feet. They'll strike or quit. A lot of people are leaving medicine because of burnout or moral injury, and I think so salaries are really going up, and that will play into what a rising healthcare costs. But and by the way, the same thing happened with inflation. If you go through the pandemic, there was actually only 1 year when we really had bad inflation because of supply chain issues. So this pandemic period, for anybody who's researching it, whether it's healthcare or anything else, it's very tricky because each year of the pandemic was so different and so in many ways unique. But these data are the 22,000 was heading that way, as you can see anyway, well before there was even a thought about a COVID-19. You can see how much it had already gone up by 2016, about 40%, 30 or 40% of the way there. So they're really rising. And the dark shaded part at the bottom of these graphs is how much the employee is contributing to get the plan. And so that went up from 4,100 in 2011 up to nearly $6,000. So that's a 50% increase. And that does not have anything to do with the pandemic. So to pay the premiums to get the coverage, employees are paying more and more. And I just want to talk about there is a use for the term out-of-pocket spending. In out-of-pocket spending, the first component is how much are you paying to even get the coverage, meaning how much are you of the premium, the cost of the monthly cost of the health coverage, how much of that premium are you paying? And that's the first out-of-pocket cost. And what you can see here is that the employers are paying the bulk of it, maybe 75, 80%. And we're going to get more into that in a second, and the employees pay the rest. And So here, what this slide is showing you is that there's different types of private health insurance. One is called an HMO, which I think Dr. Dolkart talked to you about, and there the work, and this is laying out the total cost of the plans. PPO coverage is a little better, so it costs a little more. And in PPO coverage, you have a little more choice of which doctor to go to. In the network, you can leave the network and you do pay more, but at least you can go to the doctor you want to see. In the HMO model, you have less freedom to see doctors outside the network that the plan creates. So let me define the word network because I don't think I have anything else in it. Each insurance plan, so charges for that a doctor or a hospital may post for a procedure. Let's say it's a colonoscopy and your patient's going to get a colonoscopy. There's two charges, first of all. The first charge is what the site where the colonoscopy is going to charge. So that could be, it's usually a hospital. It could be some outpatient surgery setting. And there may be some specialists who do them right in the office. So the site will create a bill and they'll create a charge, the amount of money they're going to ask to be paid. And the second fee is the doctor usually who does the colonoscopy will also send you a bill and charge you a certain amount of money. So those are the charges. Next week, we're going to talk a lot about the difference between what it actually cost to sterilize the room where the colonoscopy was done between one procedure and the next one that's done, and what the cost of having nurses and other staff available to stock the room and to do various things. But here we're just talking about charges. What does the doctor in the hospital charge the patient? And what goes on is that the insurance company, and even Medicare and Medicaid, and this goes on in most every country too, the doctor may want to get paid a certain amount of money, but the insurance company or, you know, the country of France might not want to pay as much as the doctor might want to get paid. So there is a negotiation between, say, the hospital and the insurance company for how much that hospital is going to charge for each procedure or for an hour of operating room time. And the hospital typically gives in a little and lowers the amount of money from what their charge is. And that decrement in cost that the insurance company succeeded in getting is called the contractual allowance. And it's a smaller amount of money than the charge. So uh, So when you're going, let's say you're in a PPO, this is number two, where you have a little more freedom to see doctors out of network. So when you go to those doctors, your insurance plan may be willing to pay 70%, not more. You're going to still end up having to pay a lot of money, and there won't be a lower charge because that doctor's out of network, and the insurance company didn't negotiate that doctor's fee down. Whereas the doctors in the network, the insurance company negotiated with them for a lower charge, a smaller amount of money, and when you're paying your copay and the insurance company's paying, it just has to get to that amount of the contractual allowance level, not the charge, the amount of money the doctor wanted to get. And what percentage of the charge is knocked off by this negotiation is variable, but often it's 20% or 30%. They'll knock off the charge. The motivation of the doctor to give in that negotiation, by the way, is that it does want people to come. And from the patient's point of view, if they go out of network and have to pay a whole lot of money, they may not have that money. So the patient's motivated to stay within the network that the insurance company has picked out. Now, the problem comes up when patients who need to see multiple specialists some specialists might be in the network, others aren't. And so patients have this choice to make about whether to go to some doctor in the specialty they need, who they don't really like, or who has a not very good reputation. Do I stay with a network to save money? This is a dilemma that is quite common. Anyway, the rest of these point of service is a little more restrictive. You have less freedom, so it's a little cheaper. And high deductible health plan is cheaper too. We're going to talk a lot more about those next week. And then they give you an average for each of these models, how much is the employer contribution and how much is the worker contribution to getting the coverage, in other words, to paying the premium. And I think one of the things you can notice here is there really isn't that much difference between all these models, but you're in this internship, and when you hear the term HMO, PPO, point of service, I want you to have heard the term. You will have forgotten what it means by the time by the next time you'll hear it in your actual work life. But you can look it up and you'll know generally what's going on with that. It's how much freedom patients have and how to go out and network and pay through the teeth to do that. So that's what's going on here. Just want to introduce the topic. If you get into the Medicare website, you'll see that these terms come up like United Healthcare, just in my area, this very tiny metro area I live in, and there's actually United Healthcare offering their PPO plan and their point of service plan, whatever. So that exists. So here's a slide on the type of coverage that people actually have. And what it's showing you on the left side are the full-time year-round workers. On the right side are people who are less than full-time, so part-time workers, but they are working year-round, so they're not just seasonal workers at a state park in Vermont that's closed during the cold season or whatever. So so among full-time workers, you can see that about 85% have private coverage. And on the other hand, part-time workers, only 65 or 67% in that range. Now, the upward little smaller little bars, those two are the uninsured. So even for full-time year-round workers, about 9% of them, 8 or 9% of them are working full-time but don't have any health coverage. And I'd like to ask you guys to take a guess, since the vast majority of full-time people are offered coverage, why would people be refusing it? And we already talked about the marriage thing, so that's one reason. It was too high is the right answer, and there's another part of that answer that we haven't gotten to yet, but the premium is not the only cost the patient faces. So I'm going to expand your correct answer and say, yeah, the premium is too high, and there may be other expenses, out-of-pocket expenses, that are going to turn out to be too high. And at the end of the day, the patient looks at the whole thing and says, I'm going to take a chance and go bare, uncovered, not have covered. So yeah, it's most always got to do with cost. And it's up to 15% here, 16 for part-time workers. Look at the bottom two rungs. That people, now I already said that some employers give money to their patients to buy onto the Obamacare market. And on this slide, they're actually included in the 85 to 87%. This lower set of bars for full-time here and part-time workers to the right, lower. These are people who are working, let's say they're working at Walmart, 21 hours a week. Walmart's plan has they used to pay only 60% of the premium. So patients who are less than 40% of, thousands of dollars, couldn't afford it. So but these workers are not paid very well. So, especially if they have kids in their household, they all may qualify for Medicaid. So, what's going on here is Walmart is paying these people this pitiful wage, and then the taxpayers are stepping in and giving their patients the health coverage. Now, if the supposed ethical norm in the United States is that you like this employment-based insurance model, you could argue that this is corporate welfare. Like, you're hiring someone, you want them to be healthy, to be able to see the doctor when they're sick, to not transmit an infectious disease at the workplace. You want them to be healthy. You're paying nothing to make that happen. You're dumping it on the taxpayers. So you can argue that this is a form of corporate welfare. Anyway, so I just wanted to raise that issue. So, but the percentage of people who are employed who have coverage is better than it is, you add these people in and more people have coverage, but who's paying for it? So anyway, that's something that's worthy of note. My stupid thing is, all right, let me try here. My slides don't seem to want to advance very well. Okay, so let's look at people who had dissatisfaction or a problem with their health insurance in any given year. And the biggest problem at the top of this list is the health insurance didn't pay as much for whatever they needed done than they expected. And the left-hand column will be, or the second column, ESI stands for employer-sponsored insurance. So these are people with a regular old insurance through their employer. And 35% of them said their insurance didn't really cover whatever happened to them very well. The second, where it says marketplace up there, that's the Obamacare marketplace, which is about, I don't know, 10% or 12 or 15, 14% of people. So a lot of them, it didn't cover things very well. And then Medicare and Medicaid do a little better in terms of they paid what the patient thought that we were going to pay. Here's one. The second one is a doctor covered by their insurance who they needed to see didn't have any available appointments. So notice on this one, this is also a pretty frequent occurrence. In primary care, there's such a shortage of primary care providers that a lot of people can't really get appointments. They don't already have one, or even if they do. It goes best for people on Medicare. And here it goes worse for people on Medicaid, that they can't find a doctor who will give them an appointment. We'll talk more about that later today. Here's one that health insurance didn't cover a prescription drug or required a very big copay for a drug that the doctor thought they should take and prescribe. This is about equal for all of them, 22% or so. Here's one, the health insurance didn't pay for care they thought was covered. So maybe that's a massage, but it might not be. It might be something more significant. Maybe another physical therapy visit that the physical therapist thought would be useful, or some lab test that the insurance company decided wasn't going to get covered for whatever reason. Here's one, their health insurance denied or delayed prior approval for a treatment. Later in the internship, we have a whole session on prior approval, but you're going to hear about that a lot, where your doctor orders a procedure that's sort of costly, say an MRI of your spine. And the doctor orders the x-ray, submit, and the request, okay, and the insurance company won't pay for that MRI if the doctor doesn't first submit that request to the insurance company. And then the insurance company sits around deciding whether they're going to pay for it or whether they're not going to pay for it and deny it. So that's called a denial of prior authorization, and insurance companies are allowed to do that. And the patient can appeal. Appeals happen in 0.5% of the cases because it's such a hassle to try to fight private insurance companies. And there are some progressive legal groups that help patients deal with, contend with insurance companies, sometimes legal aid, and other legal groups. Also a unique expense to the United States for the most part. here's one, their insurance company denied or delayed prior approval. We said that particular doctor or hospital they needed was not covered by the insurance, so they're not in network. And the patient either didn't know it or really wanted to get care from someone out of network. And that one is pretty high for these poor access to care. You're going to see tend to be low for Medicare and higher for Medicaid, or Medicaid will be equal to the private insurance one. So Medicaid patients insured through Medicaid have issues. There's mental health. That's a problem for a lot of people. More so in patients insured through Medicaid. They reach their limit on the number of visits or services that would get covered, so that's not as common. So let me go down. Somebody could tell me why my slides don't want to advance. Love to know.
You should be able to put your mouse on just like the arrow forward.
Show me. I'm getting help here. I have an on-site consultant, my niece.
Oh, yeah.
This is Andrea. Hello.
Hello, how's it going? Okay, where? Okay,
Is it being blocked?
Yeah, move that.
I don't know how to move this.
Yeah, that's really annoying. Just go to OK.
Yeah.
Which
It normally works with this.
okay. Oh.
Or that. No, it didn't.
Can you why is it so strange? Which keyboards is it? Let's see.
They both should work.
Sorry. Oh man, this is rough. Okay. Maybe you just click on it. That seemed to work, right?
I don't know why it worked.
I think because your mouse is doing that control.
All right. Okay, so
Okay,
here's,
thank
you. Thank you, Andrea. Here's what might be the next slide. Yeah, here's the next slide. This one is about nearly half of adults who had a problem with their insurance in the past year said their biggest problem was not resolved to their liking or not resolved at all. And that one, the blue bars to the left are the bad outcomes where it wasn't resolved well. I'm sorry, I got that backwards. Forgive me. Scratch that. The ones on the right are the ones where it wasn't resolved well. And what you're seeing is that that's a little worse for the marketplace Obamacare plans and worse for Medicaid. And it's looking like it's least worse for Medicare patients because that's only 13%. So Medicaid worst, Medicare best, and that's probably going to be a trend, although marketplace looks pretty bad for this. Evidently, these marketplace plans do things that make people dissatisfied with the coverage, which usually means not paying enough. You know, they can't see the doctor they want to see. Man. Okay. I guess if I combine my mouse with an arrow, it seems to go better. Okay, so earlier we talked about the cost of premiums. Here, we're talking about other out-of-pocket costs. And there's sort of two others. One is the deductible, and the last one is the copay or co-insurance. And the deductible, when you're working on your deductible, those are the first, say your deductible is $500. You might have stayed in network. You might have done everything right, but until you spend $500 out of your pocket and the insurance company knows about it, they're not paying a single penny. So that's called a deductible. The first procedures you have done starting January 1st when your plan begins, that's out of your pocket. And what you're seeing here is that this is for a deductible of $2,000 or more. And this is just single coverage. It's worse for family coverage. And what you're seeing is that if you work for a large firm, you're 22% of the people had 2,000 or more dollars, where their health insurance didn't pay for anything till they spent $2,000 out of pocket and demonstrated that to the insurance company. On the other hand, the upper bar are small firms, and 45% of them are providing coverage where you're spending $2,000 out of pocket before the insurance company covers anything. And the middle one is combining the two. So here's, okay, so the insurance cover plan, people have a lot of issues. That was 2 slides ago. We saw all the issues. The doctor they want to see isn't on the network, or they couldn't see him, or they couldn't get an appointment. All those issues, paid less. And then people have these huge deductibles. But when you actually do a survey, um, it's kind of interesting what the results are. That, and what you're seeing here is that most people, if you survey them, they regard their coverage as excellent or good, even though so many people have crappy coverage that they don't like. And I don't have a lot more to say about this. I just think my own belief is that people have really low expectations in the United States. My niece Andrea, who you just met, she was describing her health plan and their strategy for getting health coverage. And I was shocked that they don't even think it's bad. And it's terrible. So people in the United States expect very little from their health insurance compared to other countries. And the way you'll confront this is when people who have lived in a developed country in Europe or Taiwan or Japan or elsewhere, when they come to the United States, if you can talk to them within the first 6 months of them arriving here, they'll be shocked by how pitiful, by all the costs that they're facing and all the administrative BS that goes on in the United States. But in general, the people who have poor or fair health rate their plans a lot more poorly. Though even that group, it only adds up to around 50, 40 or 50, 45% or so who really don't think their plan is very good. And I really think this is due to low expectations. Yeah. Okay, we're trying to get to the next slide. 10 o'clock, we gotta take a break soon. Might have to. All right, I may give up in a second. How about if we take a break now we'll have 2 breaks, and right now we'll take a 10-minute break. I'm gonna take my dog out for a walk, and then I'll go to the bathroom. So we'll reconvene at 10 minutes after 10, and hopefully I'll resolve this another technical problem in advancing my slides. Thank you so much. I'll be back. But so another type of health plan that also is pretty unique to the United States is called a short-term health plan. So what's going on here is that someone left their job and either they're going to end up in uninsured, or they were uninsured, or they're going through a gap period where they didn't get another job right away. So they want to get interim coverage between the old job and the new job, or maybe qualifying for Medicaid. So there are these things called short-term health plans that the Trump administration extended from the maximum allowable period being 3 months to being an entire year. The coverage is theoretically for people between jobs. That's the typical thing. And you can renew the plan under the Trump modification of this concept. The American Cancer Society estimates for a patient with a diagnosis of breast cancer that the coverage is $8,000 per year in an Obamacare exchange plan, but $50,000 a year if you're in one of these short-term plans. So the coverage is fine unless you actually get sick and need to get care. So they're crappy, is the concept. On the other hand, if you had breast cancer prior to enrolling in the short-term plan, then you pay 100%. So that's known as a pre-existing condition clause. And I can't even keep track of all the complexity in the Obamacare legislation. But for for the marketplace and for the insurance for large employers who are providing coverage, the excluding pre-existing conditions. In other words, a condition you acquired before you got insurance with that company, that was supposed to be prohibited, but not with a short-term plan. So in other words, if you enroll in the plan and you already have breast cancer and are being treated, then you're going to pay 100%. And that's the way it used to be for most plans. Or a common variant of that was you would pay for the out of your pocket for the first 11 months or it's like 11 months or 12 months, and you would pay. And then after that, if you kept the insurance, they would finally cover you. So that's kind of the concept of a pre-existing condition. And these short-term plans are allowed to do those things. Okay, so this is a political football a little bit because Trump made it so that you could get this coverage for an entire year rather than just 3 months. On the other hand, man, now it doesn't want to advance again. Okay, so this is Biden, President Biden, and he's didn't do anything, but now finally, starting September 1st, a couple of months from now, you're only going to be allowed to get these plans for 3 months and only renew for one extra month, as opposed to Trump allowing a lot more. And this is actually a great example of uh, the rhetorical and political aspects of health insurance regulation. Trump will make the statement, yeah, these plans may be crap, but that's what they wanted. They wanted to buy it, and you liberals won't let them buy it. You're saying they can only be 3 months. Well, what do you want them to do then? And at least if they get strep throat, maybe the plan will pay 60 or 70% of the cost at the urgent care center. And if that's all that happens to you, you might have liked it. I don't know. So, or if you break your wrist, you need a cast for a few months, maybe they'll cover most 70 or 80% of that. So you could be happy. But this is kind of a good example of the politics that go into regulation of the insurance market. So I don't know if you caught this because you may be too young, but when Obama was running, was hawking, was promoting was promoting Obamacare in 2009 and 10, he made the statement, nobody's going to lose their coverage because of Obamacare. But that wasn't true. And so he got criticized justifiably. He could have made the statement, we're not going to let you get really crappy coverage. That's what he could have said. But instead, he just said, no, nobody's going to lose their coverage. Well, here you are, you have people who are losing their coverage because of Biden. Would anybody want this coverage? Yes, like apparently some people do. It might give them a false sense of security, but it's a sense of security nonetheless. And this is the kind of things that comes up with politics. The Democrats typically are requiring insurance companies to provide better coverage rather than worse. And then the coverage is more costly. Like a short-term plan would be a lot more expensive if they didn't have a pre-existing condition clause. So people are paying less and feeling good about it. Maybe they don't understand the plan. And then the Democrats end up with more expensive coverage. The costs either way are high, and that's how it is with the United States plan existing system, that it's like a balloon, you push on one side and it just bulges out the other side. So the two political parties generally have those positions, and this was a good example. So 250,000 people got support for their healthcare costs through GoFundMe in 2019. That goes up each year. And GoFundMe now has competitors, so if you wanted to do a study of this, you'd have to include all the competitors. I was surprised. I prefer to give people money directly if I want to. And they take 15% of the money, which is kind of surprising. That's a pretty high administrative cost level to take 15% off the top. So this is, and you're begging, so this is not the ideal way to get health coverage, but this is the US. So using your health insurance, So here's kind of how it goes. You and your employer together pay certain portion, pay these premiums. At the doctor, you show your insurance card. The insurance company may have negotiated a lower fee, the contractual allowance. On the other hand, if you don't have health insurance at all, you pay a high fee, the total charge, and not the lower charge the insurance some insurance company that other people have might have negotiated. So uninsured people really get shafted here because the charge is a negotiation point. It's not really, the doctor doesn't really expect to get that total amount, the higher amount of money they might want to get. So the expectation is there'll be a contractual allowance. Anyway, you'll pay 100% of the resulting bill until you reach your deductible, which for a lot of people is $2,000. Beyond that, the insurance company's still not paying 100% because you might have either a copay where for primary care it's $5, for an ER it's $100, for a specialist maybe $50 or something. That's a copay. Or a co-insurance where it's by percentage. So the co-insurance thing is common for drugs, where you pay a percentage of the cost of the drug. Your insurance plan will pay 80%, you pay 20%, and we're going to get to the cost of drugs later in the internship. It's a whole lot of money for new drugs. So the co-insurance tends to be can be pretty costly when it's done by percentage. Anyway, so you pay your copay. Um, you'll be getting mail both from the insurer and provider summarizing all this and repeatedly sending you bills or descriptions of what happened. It's administrative costs. So now we're going to start looking at all this from the point of view of an insurance company leader, like who has to do planning, strategic planning. So we're putting on a different kind of cap now. But let's just look at what insurance companies do, a private health insurance company. They pay medical costs. In other words, you go to the doctor, they pay a part of the bill after you've reached your deductible and after you paid your copay. So they pay the remaining amount. They have a department that tries to get out of paying bills where they do denials and at least delay coverage. They're arguing that it's not medically necessary because insurance companies are authorized to both dig into your medical record. There's no privacy. When you sign up for private health insurance, you sign your privacy away. They get to review your record. And they can, based on that review, they're never going to see you or examine you. They're just going to look at your record. So based on the documentation in your record, they're either going to say, yeah, okay, we'll pay this one, or nah, this doesn't look to us to be medically necessary. So we're going to start hassling your doctor and seeing if your doctor can beg on your behalf, and still gets denied. A lot of people give up. So anyway, so there's departments there that do utilization management and this kind of stuff. Then there's customer relations. And by that one, this is when you call in with a complaint or asking some part of your coverage if you don't have the details there. So, if you want to know if you can get another physical therapy visit or what it would take if you've reached your maximum, you'd call on the phone. And there have to be employees to contend with those costs. Then there's provider relations. The insurance company goes out and makes sure that there's a doctor from every specialty in their network and that the hospitals are in network that are in that community, the patients would be most likely to use. Another strategy is to not cover the closest hospital intentionally. That could be done. And just to ask, let's give it to you guys. Let's say you're an insurance company and you're covering a city that has, I don't know, two hospitals, say, or three. You can decide whether to try to cover all three or not to. what do you think the advantages and disadvantages of those two decisions, that type of decision would be?
I suppose one advantage of trying to cover more beyond just allowing you to advertise that then and say, hey, we have a greater share of the market.
That's a good reason.
Theoretically, you could also use them to compete against one another in order to bring down the charges for the insurance company. So, hey, we can cut you out of the market. You're going to lose this population that's, uses whatever our insurance policy is. And unless you bring this down into something more amenable to the rest of the group. So you could use it for negotiation as well.
Yeah, so that's a good reason, especially, well, that's a good reason. Do keep in mind though that increasingly for the last 20 years especially, the health insurance system in the United States is kind of like a game of musical chairs, where if you end up with a chair, you're happy. And that I was saying that about the satisfaction that people have such low expectations. So in the United States, more than in most countries, people might be more likely to not get angry about narrowing a network. But I think the reasons you gave were great. So what are the advantages on the other side of offering fewer hospitals? A little more costly to go to every single doctor and certain specialty. Other ideas too?
We were also discussing during one of our talks yesterday about how having several hospitals like in the same city, if there's an emergency and you don't specify which hospital you want to go to and you end up getting taken to a hospital that's outside of network, then the insurance company would have less responsibility to cover associated medical bills there.
Completely correct. It's exactly right. They're actually hoping that people will use the wrong hospital and then they can get out of paying. So might improve their profitability. Any additional ideas? Well, I got one more. If there's two hospitals in a city and you only contract with one of those hospitals, the vast majority of patients insured through your plan are going to go to that hospital that's covered. And you can maybe get a better contractual allowance because they're going to get 100% of the covered people in that city. So you can call it a volume discount. Instead of getting half the volume in the city, they may go up to getting, 90 or 95% of the volume. They'll have more business. This would happen especially if you're overbedded. The term overbedded means there's too many hospital beds in your community. You have too much capacity. So if they're having trouble filling beds, they might give a better discount, but only if the other hospital is excluded. So this kind of stuff happens. And anyway, so that's that. So quality measures, that's an activity, and we're going to talk next week about what these quality measures are. But before we do that, I want you guys right now to tell me what you think. How would you measure the quality of an insurance company? What would be the metrics you would elect to include in evaluating the quality of an insurance product? Profit company that's sold on Wall Street. So that's one. What else? Kaya?
Perhaps like the variety of what they cover. You're going to want to select an insurance agency that kind of covers everything that could happen to you. So that way it's not narrow and you get screwed over when something random aspect of life happens.
Yeah, so I'm going to broaden that and just say that they're providing broader coverage, better coverage. You're covering a higher percent or a larger network of doctors, smaller copays one way or another. Is that fair, Kaya? Okay, so better coverage could be a better quality insurance company. One more. I'm not going to give you the right answer today. We're going to talk about that next week. Benny, just one more idea. How would you measure the quality of an insurance company? The first two answers were reasonable answers and the ones that you would think would be the answer. But Macaulay's actually closer to what actually goes on. So we'll get more into that next week. it's anyway, we'll talk about that next week. So there's a quality measure department, and for the rest of today, I think we can ignore that department. It's not, it probably wouldn't be particularly large, in terms of number of employees or the cost. But anyway, so there's has to demonstrate some quality metrics. And then there's marketing and advertising. Like people have to know about your plan. So you have to somehow get it to the public. Now, keep in mind that, as I said, getting coverage in the United States is kind of like a game of musical chairs. So who would you be marketing to, the employers in the community or actually to regular people? So that's another question. So you have to come up with a plan as a strategic leader for an insurance company of who you would want to have buy your plan. And there's two varieties we're going to talk about a little later today. Then there will be a department for lobbying. All insurance companies have a lobbying department. So that may not be very many people, but they're likely to be highly paid. It's often subcontracted to full-time lobbyists who may be lobbying for some other companies too. The professional background of a lot of lobbyists is legal. A lot of them were trained as lawyers. And typically the lobbyist for an insurance company there'll be also a lobbyist, not in the insurance company, obviously, who's opposing what the insurance companies tend to do, who's an advocate for the people. There'll be progressive groups. PNHP doesn't do too much of that, but lobbying to support people in their struggles against insurance companies. So they may lobby against whole types of policies and against pre-existing condition clauses, things like that. So there's a much smaller number of lawyers on the side of sort of the people against the insurance companies. Anyway, and then CEO compensation. So in the United States, a CEO of a nonprofit insurance company like Blue Cross, like ours, get paid, I don't know, $500,000, $600,000, maybe more. And there'll be other high-level administrator CEOs who get paid a whole lot of money too. Those amounts are, as I said, are much higher in the United States, but as a percentage of the amount of money going through the company, it does, it's a tiny percent, but it's sort of emblematic of what goes on. Anyway, so additional activities, we're adding on, what if it's a for-profit company sold on Wall Street? So then you have to generate profit, and otherwise the investors are going to sell. However, not-for-profits can be pretty aggressive and can be building empires too. You did not hear that because that's this afternoon. Dr. Verhoff is going to give part 2, and he's going to talk about a lot of this, of what very aggressive not-for-profit big tertiary care hospitals. And in the book, The Hospital, the author diverts a little and talks about the University of Pittsburgh. This was kind of a leader in being an aggressive not-for-profit. So the difference between profit, which is what you would call it for a publicly traded company, and retained earnings for a not-profit, like the University of Pittsburgh's hospital empire, they start to not be that different. But the difference lies in the fact that if you're publicly traded on Wall Street and you have a bad year, you could lose your investors. And if you start losing your investors and don't have retained earnings, then you may not be even you may not have enough money to pay for a bad year in terms of medical expenses. So that's an issue. So it's not so optional like it is for not-for-profit as to whether you're going to get profit or not. You really have to. The for-profit company can have a paid board of directors. The big ones all do. You have to give dividends to investors or they won't want to invest. So there's two ways the holders of your stock can get money. One is to get dividends every year. And the other is the stock price goes up. Then when you sell it, you get more money than the lower amount you bought it for if the stock goes up. So those two, is that spelled wrong? Anyway, those two are sources of diversion of money out of the insurance company, not going to medical expenses, but going elsewhere, other costs. You can call them administrative costs. Diverted healthcare money to other uses like investor dividends. Also, investor relations, you have to send, I own some equities, and so I get mailings from them saying how this company's doing this year. And then they have an annual meeting and they have to tell you about that. And, so that kind of stuff. There'll be a few jobs. I don't know how many to, sending stuff to their investors. Fees related to public trading. If they're on Wall Street, there's a fee and they have to pay that. So there's all these little fees that kind of add up to. Okay, so I was just saying that I was just talking about some of the expenses that say a for-profit has, or either a not-for-profit. They pay their CEO, they hire all these people to do utilization review, they hire a customer relations staff, provider relations staff. They have to spend all that money to keep the insurance company going. And so that's one set of costs. Those are lumped into being called administrative costs. Then some of the money is going to the doctors and hospitals for medical care their patients received. Those are called medical costs, obviously. So the insurance company's goal, and a typical, is to reduce the medical costs as much as possible by covering only one hospital in the community, by denying procedures as being medically necessary, by having a big deductible, because then they're not paying, the patient's still paying. So what they really do pay is what they're calling medical costs here. And so the difference between the total amount of money that goes into the insurance company in the denominator, and the numerator is medical costs, the money that's actually going to doctors and hospitals. That's called the medical loss ratio. And Dr. Dolkart, did he get into this? He didn't. Okay. Anyway, so that's the medical cost ratio. And typically it ranges from 80 to 90 for private insurance companies. If you're in a country with a super efficient single payer system, Canada in some years has been as low as 0.9%. So if Canada, the Canadian healthcare system, were an investment, you wouldn't want to invest there because almost all the money is being, given over to doctors, and that's not going to enrich their retained earnings or their profit or add to anything that benefits the insurance company. So you can see that from the point of view of an advocate for patients, you'd say, well, why are you trying to minimize medical costs and call it your loss ratio? Like, you're there to provide care. Why are you trying to provide less, but anyway, what actually goes on is for-profit companies, when they have mailings to their investors, they all report their medical loss ratio, and the investors want to see that be as low as possible. So they would like 80%. In the Obamacare legislation, there was some kind of clause where it had to be 85 and couldn't be as low as 80. Like they had to be spending at least 85% of their money on actual patient care. That's what Obama wanted, Obamacare included. And can you think of a sneaky way for an insurance company to get around it if they were like making a ton of profit and their actual medical loss ratio were, say, only 81 rather than 85? So they're sending less money out to the local hospitals and doctors. How might they be able to make that loss ratio look better, look higher? This is a hard one. If you don't get it, I understand, but
Could they take on more high-risk patients?
that would work. They would be losing money. I mean, that would be real. That would be real. So that would work. It would lower their it would increase their medical loss ratio, but it wouldn't be making them more money. Okay, I'm trying to make it so that they're allowed to make a lot more money, or or more money, and get by this 85% Obamacare requirement. A higher amount out as medicine. This is a little counterintuitive, this whole thing. That's why you just said that. Their goal is to pay as little as possible to the doctors and hospitals. So there's no motivation here to be more efficient. There's in some ways a motivation to be less efficient. Let me just say, so say 80% is going to medical costs and 20% is going to administration. As we, in that previous slide, we already saw there's all this different stuff going on in administration, utilization management, quality stuff, CEO salary. And then there's profit. So the stockholders really don't care, in a way, don't really care about the actual medical loss ratio. They just want to know how much profit, the portion of their administrative cost that's their profit. So it's a funny statistic, and because it's not really what the investors should care about, but it always seems to be reported. And it's just an odd notion. Okay, I'm going to give you the answer because I don't want to spend too much time on this. But here's the idea. What if you bought up the doctors and owned them? I mean, I know this sounds like slavery, but sort of is in a way that you're buying the working life of the doctors. Yeah, it's not slavery. Okay, so this is wage. Let me think. It would be called wage labor. It's very much not slavery. They're dependent on you for their income. You can't speak against the company or they'll fire you. They may not increase your wages. So there's a lot of reasons why you might not want to be paid a salaried employee of an insurance company. However, what if you pay them enough, a little more than average, so that you divert some of your profit over to the subsidiary that provides medical care? So there's something called Optum Health, which is a subsidiary of the largest health insurance company in the country, which is United Healthcare. 1 out of every 10 doctors in the United States is an employee of Optum Health in many specialties, including primary care and specialty care. So that gives them tremendous control over where their auditing department puts profit and loss amounts. And it allows them to manipulate it so that they can be diverting a lot of money to profit, but they can make the spending within Optum Health absorb more money. They can divert more of their money to Optum Health, which they own. So it's a very strange thing, and I just want to say, I realize that the term own, and I even used the word slavery, but this is not slavery, but it can be very stressful for doctors who are working for these companies for many reasons. And we're going to talk about unionization later, and it's this kind of thing that has led to doctors kind of fighting back with the union movement. And if you're wondering why they would want to be working for Optum Health, one of the big reasons is that it's an administrative nightmare to contend with all these insurance companies and all the regulation in the United States. And whereas they're fresh out of residency, they have training, and they're 200,000 or more of debt from both undergrad medical school too, and they couldn't pay it back during their residency because they weren't earning enough. So you just take a job for Optum Health and there's your paycheck coming right in, rather than putting out a shingle and saying, I'm going to start a practice, which is a lot of effort. So the complexity of the US healthcare system adds to this. Interestingly, Canada is so simple that most doctors are in private practice, and it's not such a hassle to do that. So here again, we talked about this already, types of private plans. So then there's the issue of surprise medical bills. And you've already sort of gotten into when this might be happening. they went to the wrong hospital that's not in their network, or the real surprise is when the hospital is in their network, but some of the doctors who work in the hospital are not in network and they weren't warned and they didn't know that. But the doctors are not in network, and so they send their bill and it's outrageous. And this is often seen after private equity, which is the most predatory type of investor. When they take over medical practices, this will often happen, that they'll just raise prices astronomically and refuse to get into networks, refuse to negotiate with insurance companies. One of the ways they can do that is by taking over let's say all the anesthesiologists in an area. They recruit into well, I'm trying not to use the word own. They employ all the anesthesiologists in an area, and maybe they lure them in by paying them a little more than they were earning before, but then they can raise their fees like way, way, way more because they're the only anesthesia provider in the area. So they basically develop a regional monopoly in a sense by owning I keep saying owning. You're going to hear other people use the word owning, and it's incorrect. It's by employing or hiring or contracting with. Sometimes it's not actually an employment, it's a contractual thing where they're a contract employee. So it's a little bit complicated, but anyway, so that can happen. And that often leads to these surprise medical bills. There recently was one of the few pieces of legislation that actually did a little that was helpful. There's some legislation to force insurance companies and providers to come up with some sort of arrangement, agreement. But anyway, if you hear other people use that term owning doctors, anybody who uses the term, it's incorrect. They don't really own them. They're some sort of employment arrangement, either a regular employee or a contract employee. And if you don't know the difference between those two, you can ask, and whoever in the group knows the answer can give a legal answer, but they're a little different. So insurance companies try to avoid something called adverse selection, and they have a variety of ways to do this. And before I get to that, I want to show you this graph. So in this internship, you're going to be shown a whole lot of slides that have numbers. And there are maybe 4 or 5 of those you really, really, really need to know. And that you're going to be shown this slide multiple times, at least 3 of the times by me, if not more. Because this one you really need to remember. And what's going on here is that this is dividing people into 10 groups by what 10% of the population on the right side are in any given year, they're the 10% of the population that were the sickest as measured by their medical costs. So in other words, if somebody died sudden death and never even went to the doctor, even though they were so sick that they died or so whatever happened, they're not in this. These are the people who actually had to have a lot of money spent on their health care, their medical care. So that's the people who are the most expensive are in the right bar. Over on the other end, on the left side, decile number 1 is the 10% of the population who are the cheapest and used almost no resources from the health insurance company that year. And even for elderly people in Medicare, in most years, nearly 20%, the first 2 bars on the left, nearly 20% of the Medicare population use no care at all. So they're really cheap for an insurance company, and they are people that are going to really have beneficial effect on their medical loss ratio because there's no medical loss at all if you don't go to the doctor. So the spectrum of health that you see in the population is shaped like this. And this graph works for any population. Let's say you're a pediatrician and you want to see the graph for children. It would look a lot like this, but maybe even more extreme, where the kids in the neonatal ICU in that right bar are like unbelievably expensive, but the average kid over the age of 1 doesn't really cost very much. Under the age of 1, there might be more costs because of all the vaccines and that kind of stuff. But, after age 2 or 3, it would be a very extreme one where the kids who fell off the roof or just had a hospitalization that they really are going to absorb a lot of the spending. So, but it works for any population. It works for the Medicare population, it works for women, works for men. And it's a very important one to remember. So when we talked about all the abuses, like pre-existing condition clause, there's an effort to regulate insurers, health insurance companies, and some of the regulation is at the state level, and some is at the federal level. So one of the big things you want to regulate is that the company is setting aside enough money in case they have a bad year and their patients are more expensive than usual. So if they're covering 50 million people, they're less likely to have a 1 year stand out. Most years are going to be the same. But if they're only covering 50,000 or 100,000 people, then they could have bad years. And so they have to have enough money set aside so that if they have expensive patients or there's a pandemic, they would be able to pay their doctors and hospitals who sign up. So that's one type of regulation. Are they actually doing what they're saying they're doing, providing promised benefits? We saw all the complaints, but even with state insurance regulators on their side, patients find it daunting and usually give up if the insurance company's taken a stand on something being unnecessary medically. There's also a sector in the economy called insurance brokers. This is a form of spending in the US we don't have elsewhere in most other countries, where you go to an insurance broker to help you find a health insurance plan. And they get money. So this is healthcare money that's going to people who are providing no medical care, diverting money to an insurance broker. This has become as particularly prominent in the Medicare program. Is there a question? Thought I heard a noise. Okay. And you can interrupt me anytime. So are they, their state may have insurance mandated benefits, and the liberal states tend to have those. So for example, women in Vermont who are in the appropriate age group have to be ordered a mammogram. The insurance company has to cover that. So there may be other mandated benefits. Typically there are. In Vermont, a liberal state, we have contraception, pap smears, mammograms, a lot of things, drugs, maybe drug treatment will be a required benefit, substance abuse treatment. So, regulations relating to the pre-existing condition clause require community rating where everybody's into one group rather than subsegmenting your groups. Vermont does have community rating, so everybody who buys the general policies through Blue Cross they're allowed to segment based on age, but nothing else. You can't pick out an employer has especially healthy employees, though the employer wants to. More on that a little later. You can make them renew the policy. How about that one? Like, what if somebody signs up for your insurance and then they're expensive that year? You could want to drop them, but the state could say you can't drop them. They paid last year. You knew some people were going to get sick. They did get sick. You can't just drop them because you don't like them. So you have to hold on to people even if they get sick. So that's a state level regulation, and there are other states where that isn't required. And then some sort of complaint or resolution process. Okay, so that's state health insurance regulation. Sounds like it would be really helpful. However, there's a little glitch here. And that is that what if you're a multi-state plan like Walmart's insurance or FedEx? What happens is you're exempt from all those state regulations. Another group that's exempt is you can do something called self-insuring. So a large company, like all these big companies like Walmart, they self-insure. So their employees are their denominator, and they're not really buying an insurance policy that includes other people, say in Vermont. So instead of their pool of insured people being everybody in Vermont who Blue Cross covers, their pool is all the employees in Walmart across the entire country. So that's a completely different concept. you could have a self-insured entity that only, or that mostly has employees in Vermont. 2 weeks from now, you're going to meet with the CEO of Springfield Hospital. That's a hospital that has 750 or so employees. That's a small hospital. And they elected to self-insure, and I hope you'll include the very deleterious consequences that had for Springfield Hospital, because 750 is not a large enough denominator. So they bought what's called stopgap insurance. So you self-insure, but you're not very big. You only have 750 employees. So you can then pay a big worldwide insurance company like Barclays of London to reinsure, to buy a product called reinsurance, so that you can still self-insure if you really don't like Blue Cross's population. So this is all sort of manipulative stuff. Like you basically are looking so that your patient population will get the least possible care as an employer and as an insurance company. Everybody's trying to get you to get less care. So the ERISA law at the federal level is the one that allowed multi-state companies and even companies within a state to self-insure, immediately becoming exempted from state regulation, state level regulation. But it does have some things like the right of appeal, like you deny care, and an ERISA company there'll have to be a process for patients who are dissatisfied with their coverage. And then there's other pieces of legislation. The COBRA one allows people to, so let's say you get fired. You're working at Walmart, you took their insurance and you've been paying your part of it, and you get fired. The COBRA legislation says that if you pay, even after you're fired, you're no longer an employee, Walmart's washed their hands of you, you can renew the Walmart policy for 18 months if you pay for 100% of it yourself, which is a lot of money, but some people do. I did actually one time. I left an employment situation, and I was going out west to work on a Navajo reservation, so I actually paid the COBRA amount and kept the insurance I had in my previous job. It was a temporary workout on the Navajo reservation. So, and then there's other regulation related to pre-existing condition clauses. Obamacare had a ton of these, which Ken should have talked about. And there's a lot of things related to confidentiality in the HIPAA one, and limitations on underwriting, which means picking out who you want to insure. Renewability, we already talked about. So anyway, there's all these regulations coming out. But notice the diagram. Does anybody know what the diagram is? It's a cartoon.
Spy versus spy.
Yes, it is. Tell us about what that is.
Oh my gosh, I mean, I have like very vague memories of it. It's just two little spies trying to blow each other up, isn't it?
Oh, well, yes, it's what it is. But the idea is that spy on the left, one of the spies, the white guy, is a spy for one country, you can say the United States, and the black guy was like USSR communist country. And they're always, and every time one of them does one thing, the other tries to counter it. And this is sort of what goes on with the regulators try to prevent insurance companies from finding loopholes. So the insurance companies find a way around the loophole, and then the state government comes back and tries to plug the loophole. And it's like something out of Mad magazine from the 50s, which you probably don't know what that is, but that's where Spy versus Spy was in. And anyway, so this is kind of what goes on. So again, I'm just showing this because I want to be repetitive. Remember this. Okay, so finally, let's just go back. Let's go back. So these are the departments in an insurance company. And if you were the CEO of the insurance company and you wanted to make it profitable, and you had extra money to bolster one or more of your departments, which department would you want to have function better? And we can leave the quality one out of this discussion. Just among all the others, which will give you the most bang for the buck?
Avoiding paying medical costs, utilization management.
Yeah, I used to call that the right answer, and that's the most important answer. But the right answer is always lobbying. So we'll just leave that. That's always, always, always the case for every industry, but including pharmaceutical, which we'll get to later, that you're going to learn about all these things that go on, and it's always lobbying is most important. But you're right, and that's the one we're going to focus on. All these other ones are helpful. Notice the first one, pay medical costs. Let's say you bolster that department so that you pay doctors really quickly after the patient got that medical care. Like you pay the appropriate amount right away because you bolstered that department. You made it more efficient. What would that do to your bottom line, your profitability? As opposed to a company that routinely takes 3 or 4 or 5 months to pay the doctor.
It would obviously hurt your profitability if you weren't able to hold on to the money for a longer period of time.
Exactly. So you want to hold on to the money because you're investing it. You're investing it either in the stock market or somewhere, and you're making money. Let's say it took you 4 months to pay. You routinely, intentionally leave a 4 months delay. You're investing that money. You're getting a return on it. And in many years, when the stock market tanks, insurance company profitability really tanks because they have to have all those retained earnings anyway. And they've got all this money that they're holding back from doctors and hospitals intentionally. So if the stock market does badly, insurance companies can have a bad year. And that has nothing to do with their medical loss ratio or any, spending on medicine, just because they're connected to the investments. And as Chris just said, they're going to use that money that they failed to pay in a timely way, and they're going to invest that money too, also. So that's one where there's no benefit at all. Most of the other ones, if you think about it, they're going to help, answer the phone when people call in, it's like, anyway. I mean, we did point out that people, especially employer sponsored insurance, they don't really care that much about how happy their customers are unless it gets really bad, because they're marketing to companies, like you guys already said, that they're going to market to the employers in the community. So how much they care about what individual people, the dissatisfaction is another question. So, but anyway, all of these are less profitable than that graph demonstrated to you, this one. So yeah, they can lose a doctor or two because the negotiation didn't go well. They can make a few customers unhappy, but they get too many of those people in that 64.9% column. I mean, that's lethal. They can't handle having a lot of that going on. So a lot of what you're going to hear about from here out is exactly on this topic. I think it was Gabrielle who first said it, is finding a way to avoid these people. Okay, so here's one way. You just get rid of them. This happened in Vermont in 1999, where a third of the 27,000 people that the Vermont health plan was covering, they decided to ditch because another insurer, a nationwide insurer called Kaiser, was leaving Vermont. So they left Vermont, and it turned out they weren't that bad a population. It's just that Kaiser's centered in California, and it was just a little bulky for them to deal with Vermont. So they ditched us, but in the process, the Vermont health plan decided that some of the people they were insuring were kind of expensive. So they figured, well, we're going to pick up some of the healthier Kaiser patients. So let's just kind of trim things down a little bit. But in 2002, so if you look at all the events that have occurred in the US healthcare system over the last 40 or 50 years, there's the drug plan from Bush and there's Obamacare. Obamacare would be the biggest event. Maybe the Clinton era child health program where he gave coverage to a lot of children. That was probably on the list. But this one never gets any publicity at all. And think about how many people it affected. So this is the business page in the New York Times from August 2nd, 2002. Aetna's strategy resulted in a tenfold jump in quarterly profit. So Aetna is one of the 2 or 3 largest insurers in the country. They reported a tenfold jump in profits in the second quarter as it struggled to recover from its money-losing spiral, but their new strategy has begun to show signs of success. They earned 108.2 million, 70 cents a share, compared with only 10.6 million a year earlier, a tenfold increase in profit. I mean, that's a dramatic improvement for any company to make. The next sentence, revenue fell to 5.06 billion from 6.5 billion. So they lost about, I don't know, 30% of their business or 28% of their business. Now, imagine if you're selling radios or, I don't know, hula hoops or some consumer product. Would you expect to earn 10 times more if you're selling 28% less of your product? Think about that. It's pretty rare. This is a remarkable thing. So anyway, it was their first profitable quarter after a string of losses and good evidence that we're on the turnaround track. So Aetna staunched its losses by trimming expenses, raising prices, and turning away unprofitable business. And notice the next sentence. It cut the number of people it insures to 14.4 million from 22 million. And they were even going to cut it further to 13.7 million by the end of the year. So here you have an insurance company who's looking at all the businesses in the entire country they cover, and they're ditching a third of them, meaning that by the time they get to 13.7, that means they ditched a third of their customer base, 8.3 million people, lost their coverage. Now, how many people here think the other insurance companies are going to be in a big rush to pick these people up who Aetna wanted to ditch? Well, they're not. In that sense, the Vermont one was a little unique because, they weren't, but these people were costing more and they weren't necessarily the Vermont situation. But this is more common where they pick out the businesses, that are costing them more. So here's the quote. Aetna is happy to see some customers go. They have been heavy users of medical service and have been costing us money. They've been costing us money doing this dastardly act of going to the doctor. The trick is not to drive away the profitable people, the people who don't go to the doctor, but who still pay dutifully into their insurance plan. So one of the ways they got rid of people was by raising their prices with surgical precision to the businesses that had a lot of sicker people in their employee group. But you can't chase away the healthy customers and be left with the sicker people, or you won't be profitable. So the Carlyle Group, which is a private equity firm that spends some of their money investing in insurance companies, noted that Aetna is on a methodical road to improvement. So this is improvement. We were always the example because we were the largest, but we're not interested in being the largest. We just want to be the most profitable. So let those 8.3 million people go. So any governmental act that affected the insurance of 8 million people should get a lot of attention. But this kind of thing, it only gets on the business pages. It doesn't get into the New England Journal of Medicine very often. I don't even know if many doctors in the country even knew about this. So, but this is how things go in the United States, and this is what information gets in different directions, and this is what happens to people who are just trying to live their lives. So I would consider competition among health insurers to be a market failure. Bad coverage always wins out over good coverage. We haven't talked about why that is, but we're going to next week. And if you think about it, you'd probably come up with it on your own. By bad coverage, I mean high deductible, high copays. Health insurance companies do not actually have useful efficiencies to offer. So if we go back to the list of the activities that they're doing, none of those activities are of direct benefit to patients. Competition among health insurance companies leads to much higher administrative costs by the providers who are being to contend with the different formularies, the different insurers, billing practices, how they deal with denials, how they require prior authorization. And another issue is the weaker position vis-a-vis providers. We're going to talk more about that next week. And as I think Nirali said, or one of you, cherry picking, trying to find the healthy people to insure, lemon dropping, trying to drop people who are costing a lot. They're the primary fundamental strategies. And for those of you who recall the endless negotiation that occurred when the Obamacare legislation was being considered, this was top of the list, and it was made public. It was, everybody knew that the insurance companies did not want to have to take care of sick people, or if they did, then all the other insurance companies would have to take care of them too. They wanted a level playing field, which, makes sense. It was the right thing for them to do from their point of view. So, but anyway, Aetna's untrimmed expenses, the CEO that year got a whole lot more money, which you kind of expect. And I think this is my final slide from this topic. Yeah, so but just to take it back to a human level, on the right side is this pie chart. And when do companies dismiss employees on long-term disability? So 24% of companies have a set number of months, often 3 or 4 or 6. They'll say that an employee who's on leave is still our employee. And then 27%, as soon as the worker goes on long-term disability, they're not ours anymore. They can still, if they have long-term disability insurance paid by the insurance company, they may have to still pay that, but they're not their employee. They're not going to get their pension payments anymore, and other health coverage, other benefits. Some companies will hold on to the employee indefinitely until retirement age on the right lower part. And then there could be other criteria too. But notice that some of them, a lot of them will be 3 to 6 months or instantly. That's half the population. So now let's go to the left side of the chart of this slide. Policy shift at Polaroid, which has now changed their long-term disability policy, leads to scrimping. Here's new worries for very sick employees. More bad news during chemo. Okay, so that's 5 words. More bad news during chemo. What do you think happened?
Based on what we're seeing here, I'm assuming these are patients who had cancer, who were on disability and were then terminated and lost all their insurance benefits.
Exactly. Exactly right. So, yeah, losing their pension, that's bad. But among the benefits they're losing is their health insurance coverage, as Nehemiah said. And I want you to think about that. You're in the middle of cancer treatment. You can't work anymore, so you no longer have income. You've got this horrible illness you may die from. And at the same time, you're done and you don't have any health coverage anymore. So what started out as a single tragedy, that you got this terrible diagnosis, came a double tragedy, you lost your job, and now, as Nehemiah points out, a triple tragedy. Now you're going to have to pay for all your care out of pocket or find some way to get insured. And for the people who could get into Obamacare, that helped. But this is how things go in the United States. And this is not you don't kick people who are down if you have any values of basic decency. So when we looked at it as a pie chart and all these previous slides with all these stupid numbers on them, it all looked very abstract and mathematical, and you might have found this talk boring. I don't know, but this kind of thing where somebody who's got a lymphoma now is losing their health coverage even the part about losing their job, maybe they're losing their job because the company didn't want to have expensive employees in their little group. So this is indecent. And this is the kind of thing that, fuels my advocacy work. But this is inhumane. And we can do better. And as you're going to learn when you do your international health presentations, other countries don't let this kind of thing happen. And there's no reason that we need to either. I'm sorry to get preachy, but this is not sanitized. This is not bleach. This is real life. And it's messy, and it's in this case pretty inhumane. I don't know what time it is, but we should break for sure.
Like 11:20.
11:20. Okay. So let's take a break for 10 minutes. That'll give us a half hour left, and we'll just tiptoe into the beginning of Medicaid. But I have time for the rest of Medicaid next week. But I want you to know a little bit about it. So we'll come back for a half hour. So anyway, I'll see you then.